investigated and managed by the Department of Endocrinology and subsequently managed by us before giving it back to endocrinology. And it's like the CPCs that we have at the institute, the clinical case presentation will be done by the clinical discussant. He has access to the history and physical examination findings that we sent to him in advance, along with the images that were provided to the lab investigations that we sent to him. The radiology will be discussed by Professor Sanjay Sharma from radiology. And after Dr. Agarwal presents his clinical evaluation and his decision making in terms of the diagnosis, the pathology discussion will be done by Professor Dinda. It's my pleasure to invite Professor Agarwal to begin with the clinical presentation.
Thank you, Professor Rajiv Kumar, and also thank you, Dr. Arava. And it's a pleasure and honor for me to be presenting the CPC. As has been told by Dr. Rajiv Kumar, this was a patient managed by Departments of Endocrinology and Urology here. And I received this 2-page summary of this patient, and this is the basis on which I would build my case. And I'm sure there would be more information available with the treating teams, which I'll be able to get during the course of this discussion. So this was a 45-year-old lady who was initially admitted at a hospital in Jaipur. And the chief complaints for her were episodic anxiety and sweating for about 2 years. She also was hypertensive and diabetic. This was all detected very recently for almost 2 months only. She had history of hirsutism and swelling over hands and feet for about 20 days. She also suffered difficulty in walking, getting up from bed, and climbing stairs. And this was also for just about 20 days before her presentation to that hospital. There was no history of hyperpigmentation, abdominal striae, or any neurological or muscular weakness. And the past history and the family history were not contributory in any way. So if I may go through these symptoms one by one to take a symptom-oriented approach to the diagnosis. Well, this lady, 45-year-old, had a recent onset hypertension and without any family history. So at 45 years age, she could well be having essential hypertension because that's a common condition. But you must also think about ruling out secondary hypertension. Few things which can be ruled out almost immediately because there were no symptoms or no suggestions of a renovascular or renal arterial cause for hypertension. But when you add to it the recently detected diabetes, we need to be looking at a possible metabolic cause or endocrine cause for the hypertension. Hyperthyroidism per se, there was no history or clinical examination findings which would have suggested it. Then you add to it the fact that she was hirsute and she had proximal muscle weakness and she had some features of water retention. These put together along with diabetes and hypertension, well, this can all be explained by simple type 2 diabetes and hypertension. Perhaps she was also having PCOS or she could well be just obese. I do not know the weight or the BMI, that's not provided. I'm sure the treating teams would be able to tell us about it. But a few other things that we should consider. Cushing syndrome, even though she lacked hyperpigmentation, but she had diabetes, hypertension, hirsutism, proximal muscle weakness, and water retention put together. These are all relatively commoner symptoms of hypercortisolism or Cushing syndrome. She also had episodic sweating and anxiety, and that raises a possibility of, in conjunction with hypertension, perhaps also diabetes, it raises the possibility of Pheochromocytoma or hypercatecholaminalism. Even though these symptoms per se can also be explained merely by diabetes. So, that is all we can make out from the symptoms. Going on to the examination findings as were provided by the initial hospital where she was treated, she was hypertensive, there was no hyperpigmentation or abdominal striae, she was hirsute, and rest of the examination was normal. She was managed conservatively with antibiotics. I fail to understand why she would require antibiotics, at least from the provided details. She was also put on antihypertensives, insulin, and thyroxine. Again, I do not know why she was on thyroxine. After she improved somewhat symptomatically, she was referred to All India Institute here. The clinical diagnosis with the available clinical features that we have, history and physical, we have to look at a differential diagnosis of type 2 diabetes and hypertension, PCOS, but we should also consider Cushing syndrome and Pheochromocytoma. Well, I would require further clinical information. This is not sufficient for me to arrive at a definite or even a working diagnosis with reasonable certainty. So the further information I should require, I should seek to confirm or refute the diagnosis of Cushing syndrome include what was the weight of this patient? Did she gain weight? Was she obese? Did she have any facial features such as moon facies or plethora? Did she have a buffalo hump? These are features or signs, reasonably good signs of or robust signs of Cushing syndrome. Did she have any easy bruisability or osteoporosis? I would like to know about the pattern and the severity of the hirsutism. If she was a premenopausal, I do not know if she was. Was there a history of menstrual irregularities or amenorrhea? And were there any visual field defects or any findings in the fundus examination? To rule out or rule in Pheochromocytoma, I need to know a little bit more about the hypertension. Was it persistent or was it paroxysmal? How many drugs did she require to control the blood pressure? And were there any other features which are not told here, such as headache, palpitations, and perhaps any features which might suggest multiple endocrine nuclear syndrome type 2 or any of the other genetic or syndromic forms of Pheochromocytoma? And of course, I do not know why the patient was given antibiotics and why was she on thyroxine. These are the investigations the patient carried with her to All India Institute. These were done at Jaipur. She was hypokalemic, she had hyperglycemia, she had metabolic alkalosis, and her thyroid functions suggested that she had secondary hypothyroidism. Her T4 was rather low with a normal TSH. And then I am presuming this because I do not know about her past history regarding thyroxine treatment. Was she suffering from some thyroid disorders in the past, and what kind of replacement she had received? But this picture by itself is suggestive of secondary hypothyroidism. Her ATM cortisol after overnight dexamethasone suppression was unsuppressed, and that's suggestive or that's a reasonably good diagnosis of hypercortisolism. Of course, we need to confirm it. And her ACTH levels were also high, quite categorically high. So we are looking at a picture of high ACTH with high cortisol, and her blood culture was done which had grown staph hominis. I do not know the clinical context in which the blood culture or urine culture are done, so I do not know why, and I can presume that she was treated with antibiotics. Maybe she had urinary tract infection, and then that's why she was treated with antibiotics. So the two significant or most important findings I can draw out of these investigation reports are the fact that she had high ACTH coupled with high cortisol levels, and she had features of secondary hypothyroidism. Now, these two things put together almost immediately light up a possibility, and that possibility is that we are dealing with ACTH-dependent Cushing syndrome, and the cause is a pituitary cause because she also has secondary hypothyroidism, and if there was a mass in the pituitary, that can well cause secondary hypothyroidism because of compression of the thyroid process. So now these are the important findings, as in the investigations I said earlier. Besides these factors, she also had hypokalemia and hyperglycemia. These two also fit in to the overall scheme of ACTH-dependent Cushing syndrome. ACTH, however, we cannot be absolutely certain about hypercortisolism diagnosis here because that needs to be confirmed by overnight dexamethasone. So far, we only have overnight dexamethasone suppression. We do not know if this was indeed truly hypercortisolism. We also need to be considerate of the fact that this ACTH production may be either from pituitary, which is more likely in view of secondary hypothyroidism, but it can also be ectopic production of ACTH. So this much is now quite apparent that she has ACTH-dependent hypercortisolism. Now, if we have a patient with ACTH-dependent Cushing syndrome, an important first step to diagnosing or managing this patient is to decide if this patient has a pituitary origin or pituitary cause for the high ACTH or an ectopic cause. And there are many features which are favoring pituitary origin for this patient, including the very fact that more than 90% of all ACTH-dependent Cushing syndrome are due to a pituitary cause. And secondly, this patient also had secondary hypothyroidism. However, there is a relatively soft point which goes against the possibility of a pituitary origin of ACTH-dependent Cushing's, that she did not have hyperpigmentation. There are few features, not very strong ones, but these favor ectopic ACTH syndrome. These include severe hypercortisolism and hypokalemia and metabolic alkalosis. To some extent, the ACTH levels by themselves, they were in excess of 200, so they themselves too can be seen as somewhat indicative of an ectopic source rather than a pituitary source. So what next? So we have a patient who has recent onset type 2 diabetes and hypertension, and we have evidence that she has ACTH-dependent Cushing syndrome. Now, the first thing that I would like to do is confirm if indeed she has hypercortisolism. And this can be done by using any of these tests, a low-dose dexamethasone suppression test or a high-dose dexamethasone suppression. Of course, that has other values as well. Or else we can use urinary free cortisol or a salivary cortisol. And once we have confirmed hypercortisolism, and high-dose dexamethasone suppression test can also help us know the source of the hypercortisolism. The next step would be pituitary imaging. Why pituitary imaging first? Because that's the commonest cause for ACTH-dependent Cushing syndrome. There's a more than 95% chance of finding a microadenoma there. Only if the pituitary imaging is negative, I think we need to investigate further. And one good way of doing that is, in light of the fact that she has high ACTH, I should be doing a bilateral inferior petrocell sinus sampling for ACTH with CRH stimulation. Unfortunately, CRH is not available, at least not to us in Lucknow. I'm not sure if it is available in AIIMS. No, it's not. So we usually use desmopressin. I don't know whether you use here. You do not. So we usually use desmopressin stimulation for IPSS, but that's something we can do. And of course, we can also do imaging to locate the ectopic source of the ACTH. And this we can do either using a whole body DOTANOC, or any of the DOTA substrates of gallium-68, or else we can straight away go for imaging, targeted imaging in way of CCT of the chest and other possible regions. So at this stage, I would need to learn about what were the imaging findings in this patient. The images that I have received on a CD, and then I discussed with the radiologist colleague of mine at Lucknow. I thought the pituitary MRI, I do not see many pituitary MRIs myself. I do not operate on pituitaries. I'm an endocrine surgeon. But I had to take help from the radiologist, and what I found that the patient had a partial empty sella, and in the dynamic imaging, there was a suspicious area of non-enhancement. Whether it is a pituitary microadenoma or not needs further evaluation. And then based on the images available, we could not make out for sure if there was an adenoma or not. The other set of images we have received were a few plates of contrast enhanced CT of the chest. And those were indicative of presence of pleural effusion. There were multiple pleural nodules. There were few pulmonary nodules as well, but there was no definite bronchial or mediastinal tumor, which can be thought about as a ectopic ACTH producing carcinoid or small cell carcinoma. And we also received contrast enhanced CT. In fact, till this moment, whatever I have discussed, I don't think contrast enhanced CT of the abdomen is very wise thing to do. I do not know why it was done. But surprise, surprise, we have a normal right adrenal gland, a macronodular left adrenal gland, or possibly multiple tumors in the hyperplastic left adrenal gland. Even though in light of high ACTH, I would have expected bilateral adrenal hyperplasia. But here we have a unilateral disease, not bilateral disease, at least going by the available CT scan. So maybe we can hear from Professor Sharma now about the imaging.
This is the abdominal CT done in a single phase contrast enhanced abdominal CT, which shows that both the glands, adrenal glands, were a little more prominent. It was more bulkier on the left side, although we also felt that this is also more prominent than the adjacent crust, so we called it hyperplastic. Besides, of course, the left one is more prominent, and in the caudal section, we saw that there is a mass which is arising from this adrenal, which probably shows some peripheral enhancement, maybe suggestive of a capsule. And elsewhere, there was no mass in the retroperitoneum. The area around the aortic bifurcation was normal, and everything else was in fact normal besides this. There was a pleural effusion on the left side, as Dr. Agrawal said, and there was no mass in relation to the tracheobronchial tree in the mediastinum or elsewhere. The imaging of the brain was also done, which was CT of the head and the MR, which was unremarkable, which didn't show any abnormality. And the MR of the sella in the paracellular location shows that there's a pituitary which we felt is uniformly enhancing, and there was no convincing evidence of a microadenoma or a non-enhancing area anywhere in the pituitary. So we felt that it's probably normal. And there is mild herniation of a supracellular cistern into the pituitary fossa, but this is a common finding. Primary empty cella is a very normal finding which is seen incidentally also in these many otherwise asymptomatic patients. So that's about it.
Thank you, Professor Sharma. Well, I stand corrected now. So, if I may put in nutshell the imaging findings, we have a normal brain MRI, brain CT, normal pituitary MRI, and we have a CT chest which doesn't contribute to the diagnosis in this patient, and the abdominal CT suggests that there is bilateral adrenal hyperplasia, and besides there is a mass. What would have been the size of this mass? 2 centimeter mass arising from the lateral limb of the left adrenal gland. So this is somewhat different from my interpretation of the images. Number one, I thought in context of let's forget about the pituitary and the chest, because they are not really major contributors to the diagnosis. If we discuss thus the abdominal CT and adrenal glands per se, we thought that there were multiple nodules on the left side and in some of the other cuts. And we could make out at least 2 distinct nodules, one measuring about 1.5 centimeter based on the scale provided in the cuts, and the other measuring 2.2 centimeters. So if it was, but I'm sure you have a better access to the images, I would take your impression more as a more valid interpretation than mine. So we now have a patient with recent onset diabetes and hypertension, ACTH dependent Cushing syndrome, bilateral adrenal hyperplasia, along with a left adrenal tumor. And that tumor is small in size, there's no infiltration to the surrounding structures or surrounding viscera. It is enhancing only to a limited extent. It's not as briskly enhancing as we would expect of certain kinds of tumors. It also is not showing us any features which might be totally confirmatory or highly suspicious of malignancy, such as presence of calcification, necrosis, and infiltration into the surrounding structures. So if I may now look at the picture beyond. what are we dealing with? Having known that there is no pituitary microadenoma and ACTH dependent Cushing syndrome, we definitely are not dealing with a straightforward case of Cushing's disease. We have high ACTH. The patient had, according to me, a unilateral adrenal pathology, but now it seems bilateral adrenal hyperplasia along with a tumor. In any case, that's unusual pathology of the adrenal gland. So this definitely suggests that we are not dealing with a straightforward disease. The next logical step would be to look for the source of this ACTH. So far, we are, I think all of you would agree that we have a firm case of ACTH dependent Cushing's and the pituitary imaging is normal. We need to look at elsewhere. I would require information about IPSS. Was it done in this patient?
We don't have an IPSS, but we have the Totonoc, which showed an intense uptake in this left adrenal lesion.
In the left adrenal lesion. And any
No
uptake?
other uptake anywhere else.
Okay, so the only worthwhile pathology we know from the Totonoc PET CT is the left adrenal tumor or left adrenal as a whole.
When it said there is a specific lesion at the lower end of the left adrenal in the left para-aortic region, a specific well-defined lesion.
Okay, so that's a very important useful information. So we have a high concentration of Totonoc or Tototop, whichever substrate might have been used in the tumor in the left adrenal gland, which suggests to me that this is in all likelihood a neuroendocrine tumor. And that kind of puts my plans of managing this patient or diagnosing the patient off the track to some extent. But let me just try to still go ahead with the evaluation. Well, at this stage, the patient came to an institute. She was brought to the casualty. She had history of breathlessness and restlessness, increased thirst, and she was conscious oriented. The rest of the examination did not, it was not different from whatever we have already discussed. The investigations which were done here again suggested she had hypokalemia, she had a metabolic alkalosis, her liver and renal functions were normal, and she had high TLC, low platelets. I do not know why, but this is a finding. The high ACTH levels were confirmed here, and cortisol levels, these seem to be basal cortisol levels, unless these were something else. Was this dexamethasone suppression or basal? These are basal cortisol levels. So I'm sure the endocrinology team would have done low-dose dexamethasone suppression or urinary free cortisol. Which one do you prefer doing here? So this was not suppressible. So we have a firm diagnosis of hypercortisolism here. And now the most interesting thing is I do not know why, or perhaps I should now know why, because the Totonoc PET CT suggested a neuroendocrine tumor in the left adrenal. The endocrinologist would have done a metanephrine estimation in the urine. The result provided to me is this, exactly this, 1415.7 micrograms. So these are the two interesting, as if this patient was already not very interesting. Now we have an added dimension to it, that we have a patient with high cortisol levels, high ACTH. On top of it, she also has high metanephrines. 1415 is a value which most of the times, almost all the times, should tell me that this is a significantly raised catecholamine level or metanephrine level. This is not a marginal rise. This is well beyond twice upper normal limit. So this is a definitely a significant one. But I should ask these questions to myself before making that interpretation. I should be sure that what has been given to me, the urinary metanephrine estimation, was done under ideal test conditions. That's because we know that metanephrine levels are tricky things to do. The patient needs to be off all such compounding diet components or drugs which can cause falsely low or falsely high metanephrine levels. We need to be sure that the patient was not under any kind of stress. And this patient was under stress. She had high TLC, possibly she had sepsis. So was she evaluated while she was not under any undue stress? Whether this was a fractionated or total metanephrine. I presume this was total metanephrine value. What was the method used? Whether this was a 24-hour collection, I again presume this would have been a 24-hour collection and not a 2 hours collection or a spot urine, which is not done usually. I should also, I even do not know what is the reference range, but I am making a lot of presumptions here that this was a 24-hour collection, and the upper normal limit in various labs using this method is about 400. We take 430 odd microgram as a cutoff. And anything beyond 2 times upper normal is taken as diagnostic of hypercatecholism. So this patient was definitely having hypercatecholism. We also need to know, based on the high ACTH and high basal cortisol, unsuppressed ONDST, that this patient has a very high suspicion of hypercortisolism, but we need to confirm it, which now that confirmation is available to us. So based on the available history and the physical findings, the biochemistry and the imaging studies, now I can arrive at this diagnosis. Is it a patient with Cushing syndrome, or is it a patient with Pheochromocytoma, or does she have both? Well, she has a very high chance of having Cushing syndrome, or rather she has Cushing syndrome for sure now, because she has ACTH, high ACTH levels with high cortisol, which is not suppressed. She has the clinical context, she has the clinical features which are suggestive of Cushing's, along with hypokalemia, diabetes and metabolic alkalosis. But we need to know further what is the source of the ACTH. Is it Ectopic or Ectopic? The normal pituitary MRI contributes to this diagnosis. The probability of ectopic goes up a little bit.
Submitted their travel forms with Anjali. Anybody else?
Absolutely.
Okay, and as far as the Pheochromocytoma diagnosis is concerned, again the patient is hypertensive. She has some symptoms which may suggest Pheochromocytoma. She has high urinary metanephrines, and the Dotonok PET CT shows intense uptake in the tumor in the left adrenal. So she also has Pheochromocytoma. Can these two coexist? Well, the answer is they can coexist, but that's an extremely rare condition, or I would say rarest of the rare. And before I consider that rarest of rare probability, I need to reconfirm the catecholamine levels under ideal test conditions. But let me assume that this was indeed hypercatecholism. Can this be just a physiological response to certain thing? Now that we know about the Dotonok PET CT findings, this perhaps is not so relevant, but in a patient with severe hypercortisolism, which is in itself a stressful condition, the patient may have physiological stress response and the catecholamine secretions may be excessive. But usually we would expect the catecholamine levels or metanephrine levels not to rise beyond 2 times upper normal limit, and so this becomes unusual or unlikely possibility. Now let's discuss a few things about coexistence of Cushing's and Pheo. Of course, this is the rarest of rare, and I feel this is not something based on literature, this is my own take on this issue. There are 2 possible scenarios. The first scenario is that we are looking at 2 different pathologies resulting in these 2 different syndromes or hypersecretory conditions. Or else there can be a single pathology causing both the conditions. Let's look at the first scenario first. That is, there are 2 different pathologies, and there is a hypothetical possibility that there is a pituitary microadenoma or an adenoma, along with there are 2 different pathologies which can be explained by a chance coexistence. Even though such cases have not been reported, to best of my information, these have not been reported so far, but it's just a matter of time. Someday this chance coexistence would appear. Similarly, there are no reported cases of ectopic ACTH syndrome caused by, let's say, a bronchial carcinoid or small cell carcinoma of the lung, along with a pheochromocytoma, but that too is a hypothetical possibility, so far not reported. The second scenario, that a single pathology causing both the conditions, though it seems more startling, less likely, but these are the conditions which have been reported much more commonly. Even though very rare, yet there are quite a few reports available. The ectopic ACTH syndrome caused by Pheochromocytoma, that's been known for us for more than a few decades now. And to date, there are more than 24 of case reports. These are still anecdotal case reports, but nonetheless, this is a known entity. As recently as the last week, there's a case report which appeared on Cushing syndrome due to ACTH secreting Pheochromocytoma. And of course, there are other, in interest of time, I'll skip a few details about these, but there are other case reports as well. And this particular case report from Japan showed a 5 centimeter left adrenal Pheo along with bilateral adrenal hyperplasia, something very similar to our case that we're discussing today. And this is the MIBG scan showing intense uptake in the left adrenal region. This is the gross specimen. And most interesting part is, of course, the patient had a typical histology of Pheochromocytoma. The most interesting part reported was that the immunostaining for ACTH coexisted in the same sections with immunostaining for various neuroendocrine markers, including synaptophysin, chromogranin A, and in certain other markers. I'm sure we'll hear more about these pathological details from the pathology discusser. We have had a few reports, 2 reports for sure from India on such cases. At SGPGI, we have managed one similar patient. So I'm able to come down to this diagnosis possibly because of that particular patient which we managed a few years ago. Otherwise, this is definitely a very, very difficult case to crack. Besides all those reports, there have been reports on Cushing syndrome due to Pheochromocytoma secreting precursors of adrenocorticotrophin, not adrenocorticotrophin itself. There are a few other extremely unlikely scenarios, such as there can be an ectopic ACTH secreting tumor with a non-functional adrenal adenoma, which we see here, and the catecholamine levels or metanephrine levels that we are looking at, they are falsely elevated. Another possibility is a collision tumor in the adrenal, which is a malignant one, which can secrete both, and that the patient has ACTH-dependent Cushing syndrome along with a pseudo Pheochromocytoma, which doesn't seem to be a high likelihood now given all these information that we have. Another extremely rare condition is adrenal macronodular hyperplasia, in which the adrenal glands are typically hyperplastic in regions between nodules. And this I picked up because I thought, looking at the images, we are dealing with something similar. I thought this patient had unilateral macronodular hyperplasia along with a tumor, and the only odd thing which didn't fit in is because our patient had high ACTH, whereas macronodular hyperplasia with Cushing's and ectopic ACTH would result in normal or low ACTH levels. So, having the information, all the information that I had, my diagnosis for this patient is an ACTH secreting adrenal Pheochromocytoma. It's an exceedingly rare condition. Just about 24 of case reports have been published. But at the same time, I feel this may be a condition which is grossly underreported. Because after all, in almost none of the Pheochromocytomas we manage, we test them for cortisol or ACTH. Similarly, in almost none of the Cushing syndrome patients, either ACTH dependent or otherwise, we test them for metanephrines, unless these present as incidental and there are no clinical findings. Also, the fact that ACTH immunostaining is very difficult to do and is not available widely, is costly, we do not do it. So, maybe there are certain cases of, there are certain Pheochromocytomas which may also have ACTH secretion, but unless we do that either biochemical or immunohistochemical analysis, we would not know if they indeed have. So our patient has ACTH secreting adrenal Pheochromocytoma in all likelihood. Besides, she also had partial empty sella and secondary hypothyroidism. How, why, what is the cause for this? I am not so sure. So I think with that, of course, this patient has been optimized, treated before surgery, and then she has been operated upon. So I now hand over to the pathologist.
Thank you, Dr. Abhi, for a really great discussion. So before I open up the final diagnosis from the house, any other suggestion or any query to the clinical discussor?
You're right, sir. The pleural effusion, I thought this is some information not available to me. There was a mention about the patient was breathless, and she was brought to the AIIMS casualty with breathlessness and restlessness. And she was treated with antibiotics. So, what could be the cause for the effusion? I'm not so sure. She was not in hypertensive crisis, that's been mentioned somewhere in the details provided to me. So I'm not thinking in terms of this patient having cardiac failure or that being the cause for this pleural effusion.
It's a unilateral effusion.
Well, it is unilateral.
And any possibility of paraneoplastic syndrome, pleural effusion, adenocarcinoma?
Yes, I did consider a possibility of, in fact, which I later on excluded or ruled out. One possibility I looked at was metastatic neuroendocrine carcinoma, type 3 neuroendocrine cancers with dissemination, because they, to my mind, what we saw, there were multiple pleural nodules. There were a few pulmonary nodules as well. That, along with pleural effusion, could well have explained the whole picture. But eventually we found there were other pathologies, so we put that lower down in the list.
Cortisol is known to induce Pheochromocytoma and DMA methanephrine can come high. So you must have removed the literature.
Yes.
This level, no.
Yes, I did. In fact, I did mention that in one of the slides, that I did consider a possibility that this patient has severe hypercortisolism. Severe hypercortisolism per se, because it's a stressful condition, it can trigger the physiological response of catecholamine secretion. Yes, that is definitely a possibility. But looking at the literature, in such conditions or other stressful conditions, usually we would expect the methanephrine levels to up to 2 times upper normal limit. This patient had methanephrine levels close to 4 times upper normal limit or 3.5 times upper normal limit. So that way made me think that this probability is less. So I'm still, as I said in the final few slides, that I'm still considering, I'm still presuming that this methanephrine collection was done with ideal conditions and the testing was done with ideal conditions. With that presumption, I make this diagnosis. Yes, that's definitely something I cannot explain. We were thinking in lines of certain paraneoplastic syndromes, but then that would usually, we would expect cytopenia and not just thrombocytopenia. Yes, it can be sepsis induced, but I do not have definite information about the sepsis part.
In your final diagnosis, secondary hypothyroidism is not explained. Isolated secondary hypothyroidism, as of now, it's very, very rare clinical entity. Most of them, whenever it occurs with the loss of other excess. But isolated secondary hypothyroidism in presence of normal pituitary is something which is almost unknown. So, how do you explain secondary hypothyroidism? And it was not borderline secondary hypothyroidism, it was very clear secondary hypothyroidism. T4 levels were rock bottom low. With normal PSS, this was done twice. So, how do we explain that?
I was hoping nobody picked up that part. You're asking the wrong person all these questions. I'm a surgeon after all. Jokes apart.
Can be explained because patient has been very sick.
Yeah.
So this is a picture of sick thyroid syndrome.
Sick thyroid. Well, yes, possibly. Possibly.
Patient was on thyroxine tank.
She was on thyroxine.
She was on
Thyroxine, but we do not know the details about the duration, the dose, and it's quite possible the patient has been primary hypothyroid for.
We don't know the level of carnothyroid in the urine.
Yes, we do not.
free T4 levels were also low. Thyroxine therapy was not started by us. Thyroxine therapy was started by patient came to us at the time she was receiving, and this was started with presumption of this ACTH producing pituitary tumor causing secondary hypothyroidism. With that presumption, both free T4 total T4 were low. That's why this thyroxine therapy was started. So if we consider MRI pituitary absolutely normal, then we fail to explain why there is secondary hypothyroidism.
Yes.
We reported as a partially empty cell.
Partially.
That's because our impression in our endo-radiology discussion, we were told that it is a partial.
That's the report that we worked on.
Yeah.
As a
So
partial empty cell.
our impression was that partial anti-solution can explain the secondary hypothyroidism.
Actually, he said that he thought it's partial empty cell.
Yes, that's what the impression given to me by my radiology friends.
Okay, I think we have to finish in time, so I'm going with the final diagnosis. The specimen we have got, obviously, the bilateral adrenectomy. You can see this is the photograph of the left adrenal, and this is the right adrenal. Obviously, the gross is now can be correlated with the radiological finding. If you see this very carefully, this is the mass of fat outside, this is the capsule. There is a nodule here in one pole of this dimension 3 into 2 into 1.5 centimeter, and total weight of this specimen is around 40 gram, and it's quite big, 8.5 into 2 centimeter mass. And if you see here, this one is basically it's more of a homogeneous with focal areas. It may be grossly query cystic change, query focal areas of necrosis. Coming to this side, this may be the part of these the adrenal where the color is little deep brown, and there is no other demarcation, but one can guess that there are small nodules are there also inside this area of this adrenal. And the other adrenal right side is smaller, obviously dimension is 5 into 3 into 3.5 into 2 centimeter, weighing a little more, 8 gram. So obviously this is also enlarged. Now this is I'm showing to those who are not initiated to the normal histology of the adrenal gland. If it is normal, then we get this capsule, and then the outside you get this zona glomerulosa, comprising around 15% of these total cortical volume, and it's composed of these lipid poor cells, and they secrete mineralocorticoids. This is the zona fasciculata, this is the major part of this cortex, and they are usually lipid rich. But when there is stimulations for by the ACTH, these lipidization reduces and they become all eosinophilic in character. And this is the reticularis here, and this is the small part, and this comes the medulla. And obviously medulla produces mainly catecholamine along with chromogranin, the chromomembrane, synaptophysin and other regulatory peptides. Now we have really sampled extensively the whole specimen. First, to pick up whether we can see some of these residual areas where the normal residual cortical architecture can be seen. So that's why we have chosen this reticulin stain to show you. If you see that this part is appear to be the remnant of these the adrenal cortex, and this whole area, it's not the typical medulla. This is a medullary area. That's why I have labeled, because it is very expanded. Normally medulla granular structure is very different. So it must be something else. And now I am coming to the from the cortex area. This is the capsule, and if you see here, there is quite a bit of these homogeneous appearance, and along with some of these remnant areas of zona glomerulosa. Now these area, if you see in high power, so they are these cells which are eosinophilic cytoplasm, somewhere also vacuolated, and they are in forming these small nodules also some areas. And in hyper, you can see that they consist of these eosinophilic granular cytoplasm in these areas. They are looking like oncocytic change. There is no nuclear atypia. So basically, this is more looking like a cortical zone of hyperplastic areas. Coming to the medulla, this whole area is a mass cell. There is no definite capsule here, but these cells are quite monomorphic, and they have got similar the polygonal in shape with the granular cytoplasm and the vesicular nuclei. Here is also no nuclear atypia, and obviously there is no mitosis here. So this one, this kind of picture typically we see in case of the Pheochromocytoma, which can occur in this medullary region. And obviously we resorted to immunohistochemistry for confirmation further, because as we know that these issue where this is the medullary mass or so-called structurally looking like Pheochromocytoma, so whether they are producing the other hormones which is causing this clinical problem. So this is the normal looking area. If you see here, this we have stained for chromoganin. So normal medullary cells can produce the chromoganin. This is the medullary tumor area. These are much larger cells, they produce now also chromoganin. And this is the synaptophysin, the same this medullary tumor area, they are producing synaptophysin. So obviously the origin of this tumor is definitely medulla. And then comes the differentiation from the adrenocortical tumors or mass. See, those adrenocortical tumors are arising from the adrenocortical tissue, they are inhibin and calretin positive, but here this tumor is negative. When you stain for ACTH, it is quite strongly positive. And also we have stained for the corticotropin releasing hormone, because rarely also these tumors themselves produce corticotropin releasing hormone. So this is negative. So this gives you very clear cut idea that what we are handling with. And then the right adrenal, when we have sampled, this is also a marked the hyperplasia of these adrenocortical cells, and these cells are mostly these pale eosinophilic in nature. So, and the medulla is here, which is unremarkable. So right side adrenal cortex also showing the cortical hyperplasia with some focal oncocytic change. Now when you try to characterize by immunohistochemistry the two important the lesions or tumor which we want to differentiate whether they are adrenocortical in origin or they are Pheochromocytoma themselves. So this can be easily done with a panel of these four. There are more panel can be added, but base panel is chromoganin, synaptophysin, and calretin and inhibin. The adrenocortical tumors are negative for chromoganin, synaptophysin mostly negative. They are positive for calretin and inhibin. And here our case is these are positive for chromoganin and synaptophysin, negative for calretin and inhibin. So this is confirming our Pheochromocytoma diagnosis. In addition, the more interesting that this is positive for ACTH and negative for CRH. So this gives a final diagnosis, ACTH secreting Pheochromocytoma of the left adrenal and the cortical hyperplasia of both the adrenal. So see, radiologically now it can be matched because these hyperplastic zones are also forming small nodules. I mean that is known, that can happen. So then if you review now very in brief, because already he has done good review, so that's why I have summarized. See, the clinico-pathology correlation if you do, so there are features of excess catecholamine, there are features of excess adrenocorticoids. Clinically hypertension, sweating, anxiety all are there, and here they have diabetes, hypokalemia, proximal muscle weakness, and as well as hirsutism. And urinary metanephrine is markedly increased, and here ACTH and cortisol is also increased. So the other common sources of ectopic ACTH are excluded in these cases. There is no lung cancer, no carcinoid, no thymic tumor, no thyroid tumor, and no pancreatic islet cell tumor. Now coming to the Pheochromocytoma, obviously it's rare itself, 1 in 200,000 is the incidence in populations. Among all hypertensive cases, there may be 0.1 to 0.5% which can be Pheochromocytoma, and they may secrete varieties of vasoactive peptides, somatostatin, vasoactive intestinal polypeptide, calcitonin, in addition to catecholamine. But obviously extremely rare to secrete this ACTH. Now as we are coming to the diagnosis of ACTH secreting Pheochromocytoma, including all the languages, there are 57 case reports. So obviously in total number of cases if you count, so they are around 65, but obviously well characterized cases are around 28, so near about 2 dozen of cases. The incidence is less than 1% of the Pheochromocytoma. There is a female predilection, 70%. All ages are reported, mainly the adult, but 4 cases are reported from the pediatric age group, and the youngest, the child is 11 months old. And they are all benign in nature, except one case which has metastasis. The etiology of the excess ACTH with Pheochromocytoma, if you look about, as I told, all the cases which are reported in the literature, they may be direct secretion by the tumor cells, which is in our case. They may be combined adrenocortical adenoma, adenomedullary hyperplasia. So there are complex situations, and rarely corticotropin releasing hormone producing Pheochromocytoma. then Pheochromocytoma with pituitary tumor and or ectopic ACTH symptom. There is a Pheochromocytoma, along with there is a pituitary tumor. So all these rare, very rare combinations are also reported. Now the diagnostic criteria of ACTH secreting Pheochromocytoma, which is already discussed, but I think this has been very well characterized by Chain's paper published in Surgery. The clinical and laboratory evidence of hypercortisolism, elevated plasma ACTH level, evidence of Pheochromocytoma by urinary catecholamine, metanephrine on VMA, or MRI evidence of adrenal mass with bright T2 signal. I think more PET scans and all those things are coming nowadays. Resolution of the symptom and signs of adrenocortical and catecholamine excess after unilateral adrenectomy, and rapid normalization of the plasma ACTH level after adrenectomy. This is a very old criteria. I have a feeling that it may have changed, though it is not been reported in any other review article now. So I think, thank you very much. Now I will request Rajiv, because the last two criteria, what happened after surgery, is very important to give a confirmatory diagnosis.
Thank you, Dr. Dinda. I must congratulate Professor Agrawal for getting it absolutely spot on. So what you discussed and what you brought out was exactly what we had. As surgeons, we actually came in when the endocrinologist had done all the work. It was actually admitted under endocrinology, managed by them, evaluated by them, Dr. Khargawal primarily responsible. We came in when we were asked to go in and take the adrenals out. We initially posted this lady, but found that she was extremely sick at that point of time. Dr. Rashmi is the anesthetist who works with us for Pheochromocytoma. Then she was aggressively involved in making sure she became fit for surgery. The issues that we were dealing with at that point of time were that she had low platelets and a high TLC, and somebody correctly pointed out at the back that this was sepsis, which is why she had low platelets and a high TLC, and probably partly explaining the left pleural effusion at that point of time as well. She required aggressive antibiotics. She also required blood transfusions and single donor platelets before we could take her up for surgery. She also had severe hypokalemia, was initially on oral supplementation and then on IV supplementation, and she also had severe myopathy. So basically she was reasonably high risk. Even before we could take her up for surgery, about 2 days prior to her planned surgery, she suffered a possible syncope or a cardiac arrhythmia. She had to undergo a CPR for a brief 3-minute period before she was revived. So we ended up having to postpone the surgery for a brief period of time. She was hypokalemic at that point, so that may have been a precipitating cause. Ultimately, we did take her up for surgery about 3 weeks after she was admitted. We chose to do a bilateral simultaneous laparoscopic adrenalectomy. We began with the left side because that clearly had a tumor. We had a 3-port transperitoneal approach for the left side. The left side went off well with no problems that I could encounter. I'm sure Dr. Rashmi had problems intraoperatively. But once that went off well, we flipped her over and decided to do the right side also. And therefore, we did a bilateral simultaneous laparoscopic adrenalectomy. The intraoperative ultimately went off well. She did require a single donor platelet transfusion and a unit of packed blood cells. She was extubated on table, but she was shifted to the ICU as a routine precautionary measure that we take for most of our Pheos. Fortunately, she needed to stay there for only a day and was shifted back to us the next day. She was started on the oral diets on the first post-operative day, but she did require a low-dose antihypertensive and insulin for the first few weeks. She required diuretics and potassium supplementation, and the answer that you wanted on the ACTH, it did come down to less than 0.01. I think this was about 5 days after the surgery, and the platelets and the TLC became normal without any further intervention. Unfortunately, she developed acute retinal necrosis on the 8th day after surgery. It was believed to be metastatic endophthalmitis. She required a vitrectomy, vitreous antibiotics, and a subsequent surgery a few days later, but the vision in the left eye still hasn't come back. A phone call about a few hours ago gave us the most recent update on how she is doing, although she came to see us about 2 weeks ago. So she is now normotensive on no drugs, euglycemic on no drugs. She is of course on steroid supplementation, calcium and thyroid, but there has been no improvement on the left eye vision. So that's the current status. Thank you. I'm sure he'd be happy to answer. He's got everything right so far.
So, once we have diagnosed it's a adrenal tumor, would you like to do bilateral adrenectomy or remove that tumor and use lateral adrenectomy? Why
exactly my thoughts. I would have done if at all required, a staged bilateral adrenalectomy. I would have started with the left adrenalectomy, tested her for ACTH, cortisol, catecholamines. If we had cured her, that's it. Uh, Especially in this patient where the ACTH source has been taken out. We do quite a few bilateral adrenalectomies in patients with undetected source of ACTH or even failed pituitary surgery where the ACTH remains high. So those patients, a drastic measure has to be taken to take out both the adrenal glands. On top of it, whatever little cortical tissue we leave behind, it picks up function over some time. So the patients may require corticosteroid supplements, but still they're not as much at risk of Addisonian crisis as this patient would be. Because this patient is now absolutely without any adrenal cortical tissue and no high ACTH stimulus to keep the cortisol functional or to keep the cortisol levels going a little bit. So yes, my answer to you is I would have done a left adrenalectomy and then waited if there was a need, which I doubt there would have been. But I think that's all in hindsight. At the time when this decision was being made, I do not know if you were also certain about this being ACTH secreting Pheochromocytoma and the other side being just hyperplastic because of ACTH stimulation.
Yes, so that was the discussion we had prior to taking her up for surgery. We were initially keen on doing only one side, but the endocrinologists were pretty clear that if you don't take both the sides out, she may not have a chance to come back to the theatre. Because she'd come back after such an extensive a stormy course pre-operatively in the second hospital before she came to us. So they were pretty clear, take out both the sides. We'll handle the hypoadrenalism. But I agree with what is being suggested.
Right side is all you were taking bilateral.
Yes,
Is there indication for a partial removal on right side?
so in fact, in this particular patient, my first choice would have been unilateral.
But in case you were considering bilateral.
We would have done a cortical sparing or adrenal sparing, whatever. In fact, just the last week, last Monday, we did one cortical sparing in a patient with bilateral disease. So, but that's a fairly standard thing now.
It was not urologist's decision. They always wanted to do one-sided adrenalectomy, but seeing the severe hypercortisolism of this patient and she was so sick, the only chance of survival was immediately take out adrenal. And by any chance, if there is second source of ACTH or if some ACTH existing tissue is left inside body, she wants a heart implant. So that was the only reason we could manage her hypertension very well in throughout her life. But only chance of survival was to remove adrenal on both sides, so there was absolutely no hypercortisolism. That was they were persistent with that. They will do first stage adrenalectomy on left side and then we'll do second side. But we know from our experience, wherever we have not done bilateral adrenalectomy, very severe sick patient of hypercortisolism, we have lost patients. So that's why I wanted bilateral adrenalectomy as early as possible, and because of other comorbidities, it was possible after 2 to 3 weeks.
No, I agree that.
That is different than other bilateral.
Yeah, so but in
But
case
we
of
only hyperplasia.
yeah, but only chance was that in case full tumor is not removed, some part of tumor is left, and there is
Just divine tumors, they come out in both ways.
Don't you use any adrenalytics to prepare such patients? Ketoconazole, or mitotane?
we have used, but most commonly available is ketoconazole, and as soon as you start, within 4-5 days, even enzymes start segregating, so then you have to stop.
Roughly about 50% patients.
They are not available.
Mitotane is available. It's expensive. It's toxic. But we use it for endocortical carcinoma more often than for Cushing syndrome. But ketoconazole, in our experience, roughly about 50% patients have liver dysfunction. The rest of the 50%, it does wonders. It improves the safety.
Will also work where there is a 2 to 3 time elevation of cortisol. Overnight DEX suppression, normal cutoff is less than 100 microgram per day, and this was more than 160. So even if we suppress 10 times, even she will remain severely hypercortisolism.
I'm not doubting your wisdom. This was definitely one option, a doing bilateral adrenalectomy so that you could have taken care of this hypercortisolism or catastrophic hypercortisolism as soon as possible. Well, this is definitely one valid option, but maybe if it is possible in a future case, if the patient is not so sick or there are other ways of managing that sick period, then perhaps unilateral adrenalectomy, cortical sparing procedures would be safer, better in long term. That's all I'm saying.
I think it's really so far as the CPC is concerned, it's a good CPC, and considering the very sick patients, and the patient has come from the Jaipur to our institute, so maybe that is the thing explained to you. Otherwise, when I was reviewing, I mean that is the point what Professor Mishra has pointed out. See, the other side adrenal is a reactive one. So if you remove the source, so obviously that could have been come back to normal. But there are a few cases of the bilateral adrenectomy, particularly this kind of situation where the very high cortisol level is there and the patient is very sick. There are, I think, out of that so many cases, there are 3 papers we have mentioned there. But majority of rest of them are mostly done unilateral adrenectomy. Yeah, there is a tumor here. So if you remove the tumor, then other side will supposed to regress. That is very rare. So
I'm going to invite Dr. Khargawa to do that, because by that time they were back. She was back with endocrinology.
No.
No, it all occurred about 8th or the 9th post-operative day. It began with redness about the 8th post-operative day and then progressed in the next 3 or 4 days. She was on she was not on DVT prophylaxis, but we did a Doppler 2 times, I think, in the post-operative period just to be certain that everything was okay. But no, she was not on Plexane. But this was not a DVT related thing. This was clearly infective.
I agree, but I'm just extending this discussion that 1 week post-operatively, the patient is high risk of DVT. One of the reasons for any vision loss or any unexplained condition would be.
No, but they had a positive culture, intraocular. So this was clearly a metastatic endophthalmitis.
So thank you very much for attending the discussion.